EPS in AVRT. EPS in AVRT usually includes recording during normal sinus rhythm, atrial pacing and atrial extrastimulus during normal sinus rhythm, ventricular pacing and ventricular extrastimulus during normal sinus rhythm, His-synchronous ventricular extrastimulus during tachycardia. Indicators of retrograde conduction in bypass tracts. Induction or initiation of tachycardia. Effect of bundle branch block during tachycardia. Recording during normal sinus rhythm. In presence of anterograde conduction in both the AV node and bypass tract, the QRS is a fusion complex, and the His potential, H wave, is activated anterogradely over the AV node, followed by ventricular activation, V wave, that is, an HV pattern is recorded. When complete AV node anterograde block occurs, the QRS becomes fully pre-excited, that is, the whole ventricles are activated via the bypass tract, creating V wave first, followed by retrograde activation of the His bundle, creating H wave, that is, VH pattern is recorded, instead of HV, a condition sometimes described as negative HV. Variations in HV during normal sinus rhythm. During normal sinus rhythm, pre-excitation may be associated with any of the following, depending on its degree. With less pronounced pre-excitation, there is short HV interval, less than 35 millisecond, due to earlier V wave. With more pronounced pre-excitation, H is buried in V, or in QRS, due to very early V wave. With full pre-excitation, VH pattern, negative HV, is recorded, because all anterograde conduction occurs in the bypass tract, ventricles are activated first, followed by retrograde activation of the His bundle, which can be followed by retrograde conduction to the atria, with a retrograde A wave, a condition known as echo beat. How to unmask or increase pre-excitation. Unmasking pre-excitation, if concealed during sinus rhythm, or increasing its degree until full pre-excitation occurs, can be achieved by slowing AV node conduction, without affecting bypass tract conduction, using any of the following maneuvers. Carotid sinus massage. AV node blocking drugs. Atrial stimulation. Atrial pacing and atrial extrastimulus during normal sinus rhythm. Incremental rate atrial pacing, or progressively premature atrial extrastimulus, produce 1. Decremental AV node conduction, with progressive AH prolongation. 2. Progressively increasing pre-excitation, that is, shorter HV, then H buried in V, then VH. Upper, after atrial pacing, S1, shown in the first two beats, an atrial extrastimulus, AES, is given. Pre-excitation is present during pacing, indicated by the short HV, 25 millisecond. After AES, the AH is longer, and HV is shorter. Middle, an earlier AES resulted in even longer AH and shorter HV. Lower, an earlier AES resulted in VH followed by retrograde A, echo beat. Stimulation site. Atrial stimulation at, or very close to, the atrial insertion site of the AV bypass tract, results in maximal pre-excitation, because of the lack of intervening atrial tissue. Failure of atrial stimulation to increase the amount of pre-excitation can be caused by markedly enhanced AV node conduction. Total pre-excitation already present at the basal state caused by prolonged or absent AV node His-Purkinje system conduction. Very long refractory period of the bypass tract. Rarely, decremental conduction in the bypass tract. Ventricular pacing and ventricular extrastimulus during normal sinus rhythm. In presence of a retrogradely conducting AV bypass tract, manifest or concealed, ventricular extrastimulus during normal sinus rhythm can result in ventriculotrial, VA, conduction over the bypass tract alone. VA conduction over the AV node alone. VA conduction over both bypass tract and AV node, a condition known as atrial fusion. Total VA block. VA conduction over the bypass tract alone. With conduction over the bypass tract alone, the VA conduction time is constant over a wide range of pacing cycle lengths, and ventricular extrastimulus coupling intervals, since usually there is no decremental conduction over the bypass tracts. VA conduction over the AV node alone. VA conduction over the His-synchronous system AV node alone results in a normal pattern of VA conduction, that is, concentric atrial activation, in which the medial portions of the atria around the atrial septum are activated first, followed by lateral spread of the activation wave, almost simultaneously in both atria. Atrial fusion. Retrograde conduction over both the bypass tract and the His-synchronous system AV node is especially common when right ventricular pacing is performed, in the presence of a left-sided bypass tract, at long pacing cycle length, or long ventricular extrastimulus coupling interval. In this case, atrial activation pattern depends on the refractoriness and conduction times over both pathways, with variable degrees of atrial fusion. The patterns during ventricular activation are shown in the following 4 figures. Ventricular pacing S1 conducts in AV node with concentric atrial activation. Early A waves appear in the proximal, medial, coronary sinus, CS, channels, 7 and 8, before the distal, lateral, channels, 1 and 2. Conduction of ventricular extrastimulus, VES, the third beat, travels in both AV node and bypass tract, with almost simultaneous A waves in all CS channels. Last impulse is a sinus beat, showing atrial A waves followed by ventricular V waves. Ventricular pacing S1 conducts in AV node with concentric atrial activation. Early A waves appear in the proximal, medial, coronary sinus, CS, channels, 7 and 8, before the distal, lateral, channels, 1 and 2. Conduction of ventricular extrastimulus, VES, the third beat, travels in the bypass tract alone, with eccentric atrial activation, that is, A waves appear in the distal before the proximal CS channels. Last impulse is a sinus beat, showing atrial A waves followed by ventricular V waves. Ventricular pacing S1 and VES all conduct in AV node only, with concentric atrial activation. Early A waves appear in the proximal, medial, coronary sinus, CS, channels, 7 and 8, before the distal, lateral, channels, 1 and 2. Last impulse is a sinus beat, showing atrial A waves followed by ventricular V waves. Ventricular pacing S1 and VES conduct in AV node only with concentric atrial activation. Early A waves appear in the proximal, medial, coronary sinus, CS, channels, 7 and 8, before the distal, lateral, channels, 1 and 2. VES VA conduction time is long, allowing bypass tract to recover, followed by anterograde conduction in bypass tract, and induction of long VA tachycardia, that is, VA is longer than AV. Note that atrial activation during the tachycardia is concentric, that is, in the AV node, which indicates antidromic tachycardia. Response to His-synchronous ventricular extrastimulus. When recording during orthodromic tachycardia, a His-synchronous ventricular extrastimulus delivered exactly during the H wave or within 20 millisecond before H, cannot conduct to the atria in the AV node, which is refractory at the time of anterograde H wave. If a His-synchronous ventricular extrastimulus conducts to the atria, it proves the presence of a bypass tract. A His-synchronous ventricular extrastimulus, VES, cannot conduct to the atria in the AV node, which is refractory at the time of anterograde H wave. If a His-synchronous ventricular extrastimulus conducts to the atria, it proves the presence of a bypass tract. Conduction of a His-synchronous ventricular extrastimulus to the atria is proved by advancement of the next A wave. Although this proves the presence of a bypass tract, it does not prove that this bypass tract is involved in the tachycardia circuit. In this schematic, the His-synchronous VES during tachycardia advanced the next A wave earlier than expected, that is, the A wave came after a cycle length that is shorter than the tachycardia cycle length. This proves the presence of a bypass tract, but not its involvement in the tachycardia circuit. On the other hand, if a His-synchronous ventricular extrastimulus during tachycardia resulted in its termination, this is diagnostic of the presence of a bypass tract, as well as its involvement in the tachycardia circuit. In this schematic, the His-synchronous VES terminated the tachycardia, with return of sinus rhythm, proving the presence of a bypass tract that is involved in the tachycardia. Failure of His-synchronous ventricular extrastimulus. If a His-synchronous ventricular extrastimulus does not result in atrial activation, there are three possibilities. 1. There are no bypass tracts. 2. Bypass tract is present, but only conducts anterograde. 3. Bypass tract is present with bidirectional conduction, but it got functionally blocked at that time, by the ventricular extrastimulus itself. Indicators of retrograde conduction in bypass tracts can now be concluded. 1. Eccentric retrograde atrial activation sequence. 2. Occurrence of atrial activation by His-synchronous VES. Induction, initiation, of tachycardia. Induction of orthodromic AVRT by atrial stimulation requires the following. Anterograde conduction over the AV node His-synchronous system. Anterograde block and retrograde conduction in the bypass tract. Induction of antidromic AVRT by atrial stimulation requires the following. Anterograde conduction over the bypass tract. Anterograde block and retrograde conduction in the AV node His-synchronous system. Induction of orthodromic AVRT by ventricular stimulation requires the following. Retrograde conduction over the bypass tract. Retrograde block with anterograde conduction in the His-synchronous system AV node. Induction of antidromic AVRT by ventricular stimulation requires retrograde conduction over the His-synchronous system AV node. Retrograde block and anterograde conduction in the bypass tract. Effect of bundle branch block, BBB, on AVRT. In patients with orthodromic AVRT, the impulse travels anterograde in the AV node, to reach the bypass tract retrograde, after conduction in the ipsilateral bundle branch. Ipsilateral BBB forces the impulse to conduct in the other bundle branch, then transseptal to the ipsilateral ventricle, to reach the bypass tract, and finally conduct retrograde to the atria. This longer journey results in prolongation of the VA conduction time, VA interval. The whole tachycardia cycle length usually also prolongs, which means a decrease in the tachycardia rate. It can be concluded that a decrease in tachycardia rate, with the development of BBB, wider QRS, is diagnostic of an orthodromic AVRT, utilizing a bypass tract ipsilateral to the BBB. Upper, contralateral BBB does not affect the tachycardia cycle length, because the impulse still reaches the bypass tract from the ipsilateral bundle branch. Lower, ipsilateral BBB prolongs the tachycardia cycle length. In this schematic, the cycle length is shorter, tachycardia rate is faster, and the QRS is narrow before BBB. After development of BBB, the cycle length prolongs, tachycardia rate decreases, and the QRS widens. In this schematic, the VA interval and cycle length are shorter, tachycardia rate is faster, before BBB. After development of BBB, the VA interval and cycle length prolong, tachycardia rate decreases. It is of note that, one should not confuse this with rate-dependent BBB, in which BBB is the result of change in heart rate, while in our case, the opposite is true, that is, BBB is the cause, not the result, of a reduction in heart rate. Thank you.